Hi, I just wanted to say congratulations to everyone forming the Billy Guyton Foundation. I really applaud your efforts, and I think there's a number of us clinicians around New Zealand who are really excited about this development. My name is Elizabeth Harris. I work as a GP in Dunedin, but across a number of areas. The emergency department, where I've just come from, I've dashed out. The guys are covering for me while I give this talk, and sorry, it's just been really busy. And then on the ward and in hospitals, and then general practice. And then I have a clinic in Dunedin with my lovely team where we see people who come in from around New Zealand. We don't advertise at all, but I think there's a real need for this sort of work. And so Shane and Pup have asked me to talk a little bit about what it is that we could be doing to change the way that concussion is managed in New Zealand, so that not just a few people who are coming, but other people who are affected could be helped. This is a slide presentation that I've put together previously, so I'll just quick run through it. So concussion, what is it? It's an acute injury, and it has been defined in a mechanistic way. It's the result of blunt trauma. Now, what I'm going to do is I'm just going to bounce through these slides really quickly, and if anybody wants the recording, I'm very happy for Shane to send it through. So I'm not going to read every slide, and if you want to read through them, that would be fine. Only just know that only 10% of people are knocked out, have loss of consciousness, and so people can sustain a brain injury without being knocked out. There's physical symptoms, so I'll leave you with this list, and cognitive symptoms, so difficulty concentrating, mood changes, irritability, and many of the things that it sounds like Billy experienced, unfortunately. And then behavioral issues as well. In Aotearoa, 95% of the concussions are mild, and so it affects a significant number of people every year. Many of them are under the age of 30. Only 21% are sports related. And so being able to address concussion for other people who aren't being affected in sports, because obviously the rugby union and other sports bodies have got a significant interest now in preventing this or treating it when it happens or addressing it. There are other people involved as well. So the problem is that there's evidence that there are long-term outcomes. So this is actually Alice Theodorm out of AUT, a New Zealand professor who put together this study that was published in the British Journal of General Practice. And what it showed was that nearly half of the participants, 47.9%, reported experiencing 4 or more post-concussion symptoms a year after post-injury. Where does that put us? Because the dogma at the moment, unfortunately, is that most people recover, and so therefore we don't need to have a broader approach to people who have concussions, that only those who've got significant ongoing symptoms should be referred to a concussion service. So the other issue is, how do we determine if somebody's had a concussion? So if it's a broken bone, we can see it on an x-ray, but if it's a broken brain, how do we determine that? And at the moment, much of our assessment is questionnaire based. Dr. Theodorm has come up with a questionnaire designed to be delivered in primary care and also secondary care. But is there any imaging that we can do for the brain? It turns out that the imaging, so say for example when we do an MRI of the brain, studies show that 70% of people who have got a significant concussion that's and ongoing symptoms, so post-concussion syndrome, who are symptomatic, have a completely normal MRI. So how are we going to determine this? This is a DTI, diffusion tensor image, and it is much more accurate. And there's also something called a MEG, magnetoencephalography. I think there is a MEG up in the North Island. But these are kind of research level investigations. At the moment, MATI, which is a wonderful organization in Gisborne, and the team there are looking at biomarkers in MRI to see if there's other MRI biomarkers that could be determined. And then Helen Danishmeyer at AUT, I think, or in Auckland, an ophthalmologist, is looking at visual biomarkers of visual tracking. And then there's studies on mRNA biomarkers. So, and what we're hoping for at some stage is that there would actually be a blood test, because the real question is that when somebody has a head injury, are they depressed, or do they have a head injury? And very often what we see is that when people go through formal review, and at times with ACC, the outcome of the head injury, when somebody is unable to work and has ongoing symptoms, they develop symptoms that look like depression. Is that native depression, or is that post-concussion related, and therefore related to their accident? How do we determine that? That's really the question. There's a number of us who feel that doing further brain imaging may be of assistance, and the question is, what would that brain imaging be like? So I'll talk about that in a wee minute. One of the things I wanted to just explain to everyone, which I have found really helpful in understanding head injury myself, is this idea that there are some areas of the brain where if there is an impact, it doesn't necessarily affect the person that much in terms of their behavior and their cognition and things. So this is a model of the brain. This is what we know, that there's areas of more or less connectivity in the brain, so nodes and hubs. And if a major node is hit, then the person will have symptoms. So now it sort of helps to explain what we see. We see some people, I've got patients who have slipped over on the ice and never had loss of consciousness, and 3 years later they're not working. And another patient who ICU intubated for 20 days, and they were going to turn the ventilator off, and somebody asked that they just keep it going for another couple of days, back at work within 2 years, 1 year. Why is that? And part of the reason can be because of the area that's impacted, and also the number of head injuries the person's had in the past. So if somebody has had a head injury, if you look at this particular diagram, there's, you could trace from the back of the head to the front of the head, and you go through these pathways, and if there's a particular area that's been taken out, then the brain can go around that. And then there's another sort of small injury, and the brain can go around that. But you get to a point where if there's another head injury, even though it's small, all of a sudden, all the connectome, all the different pathways, there's no fast pathway anymore, and it has to go the long way around, if that makes sense. And so then we see people who've had minor head injuries all of a sudden become really symptomatic, and then the information that the patient might receive might be something along the lines of, well, it really doesn't make sense that you're so symptomatic, and we're sort of wondering, if there's something else going on, like you're depressed or something else, and we're going to put it down to that possibly. But we're a whole system, so it's not just about the brain, it's how the brain interacts with the whole body. And so there's this particular paper that I really like, looking at the different components of what goes on in a head injury. In our present system, we'll treat people by sending them to a concussion clinic where they'll see a physio who will look at their neck, and the physio will also look at their vestibular, that's their balance system, and they'll see an OT who looks at how they're interfacing with work and their activities so that they can modulate those and not overdo it, basically. The interesting thing is that this particular model doesn't cover what is probably the main area that's affected in head injury, and that's inflammation. So what I say to patients is, if you imagine when you accidentally whack your arm, it becomes red and swollen, that's inflammation. And it happens so that the body can attract various cells and molecules into the area to heal tissues that have been damaged. That same inflammation process occurs in the brain when somebody has a head injury. And our increasing understanding is that when people have ongoing symptoms, a large part of that is because of ongoing inflammation in the brain. And so the question is, can we treat post-concussion syndrome? Can we turn that inflammation down? And the answer is yes. It's very exciting. So what we have to ask is, if the brain is affected, how do all the systems in the body get affected? Because the brain largely, runs the body. And why is that important? And so maybe this is me turning the recording on and off. Hang on a minute. I'm just going to jump through a little bit about what we do. This is in our clinic. We have an altitude simulator. I'm going to come back to the neuroinflammation. We have an altitude simulator. This has been proven to improve something called phase angle, which is to do with cellular health, and VO2 max, so the efficiency of cellular activity. That's what it's been shown to do. We think it does a couple of other things. When people have a concussion, we'll put people in our hypobaric, it's the opposite of hyperbaric, and we see about 70% of people responding to that. We run a couple of other things, something called flow presso, temperature biofeedback in the front of the head. But so then jumping back to inflammation occurring and how that impacts the body, there's different areas that we'll address in the clinic if somebody's not getting better. So here's a paper showing that what's going on in the gut. So the microbiome, that's the term for the organisms that cohabitate with human beings, and we've got a lot of those in the gut, actually interface with what's going on in the brain. So there's this gut-brain axis, and then the gut can be affected because the nervous system that powers the gut, when your tummy gurgles, that's the gut having a peristaltic wave that's driven by something called the autonomics. That's the automatic nervous system that you don't have to think about. And that automatic nervous system gets impacted, so then the gut gets impacted. Then just like a stagnant pond, you need water to flow through a stream so that it doesn't build up algae. If the gut's not moving properly, then bugs can build up there, and those bugs can release inflammation inducing molecules that get into now a leaky brain, because the brain can be leaky after a head injury, and cause inflammation. So you can actually heal the brain by healing the gut, and knowing which patients have got something going on with their gut that needs healing, and which have something else causing them to be held up from their head injury is part of the pathway that we're following in our clinic, and many people around the world are following as well to get people better. And so here, this is a microbiome analysis from a patient, and you can see, and we've got some patients like this at the moment, poor things, because blasto and dientamoeba aren't great. So this is a advanced test. We don't have this available here in New Zealand. We have to send it overseas, and there's some special distributor companies that do that. So this is a patient with ongoing concussion syndrome, and they've got 2 parasites in their gut. And because the parasites are there, that keeps inflammation going in the body, and that inflammation is leaking to the brain, and it doesn't allow the inflammation in the brain to settle down. And so here we see this person with their blasto and the dientamoeba. So then I talked already about the autonomic nervous system, and that's driven by a nerve called the vagus. So for the gut, the vagus is the 10th cranial nerve, and it innervates quite a large area, the lungs and the heart, and most of the intra-abdominal organs. And so we can rehabilitate the vagus if it's affected following a head injury. One of the ways we can do that is by training something called heart rate variability. And so this is a program, HeartMath, that we use in the clinic. You can see it's kind of the person's heart is going faster and slower. And if it does that in a nice sinusoidal pattern, and the heart waves, the frequency of the waves all come together, that helps the body to re-regulate. And here we can see it's a little bit jaggy, and then it's become nice and even. And so this can actually be run on a cell phone, on an app. And so then there's people around the world who are working on addressing hormones. So there's research, a lot of research, to show when people have a head injury, the ongoing inflammation in the brain can be caused by a reduction in hormones. And so here's a paper talking about inflammation in that hypothalamic pituitary adrenal axis that's to do with hormones and head injury, and there's many papers. So this work has been championed by Dr. Mark Gordon, who I've trained with and had dinner with, I guess, a couple of weeks ago. I was in America in 2015 when I did the training with him. There were 1,500 patients on his waiting list. His statistics out of his office in 2021 show that 70% of people with long-term post-concussion syndrome respond to a hormone approach, and if they're military, about, I think it's 83%, because they're kind of better at taking supplements, because often we run supplements and hormones to reduce the inflammation in the brain. So here's another paper about testosterone affecting the brain following head injury. So people who have got, for example, low testosterone can be symptomatic. The other thing that we'll look at is, so we've talked about the brain concussion here in New Zealand, and the different areas of the brain that's affected, and what causes somebody to have ongoing symptoms, and that would be inflammation in the brain, and why that inflammation might be ongoing. And we've talked about hormones, and we've talked about the gut, and now talking about biochemistry. So some people have heavy metals. This is a hair mineral analysis from one of our patients. This is arsenic, and you can see their arsenic is very high, and that's going to cause inflammation as well. And so this is a great paper I recommend to everybody about how there's more inflammatory instigators in our society because of colors and preservatives and chemicals in food and sprays and all of those sort of things that hold the brain up from being able to heal, just like arsenic would. And so in terms of other therapeutics, shining light on the head can be very helpful as well. So I'm really sorry, because it's a really fast kind of run through some things that we're doing in the clinic. I think to address some of the questions that Shane posed is what's the potential for us? And one of the things I'd like to talk about, so I've talked about what we could do for people with long-term concussion to be able to help them. How would we implement that? I think we as a group need to have strategic meetings and figure this out, because it requires a really different way of thinking. In standard medicine, we have a very singular pathway. We make a diagnosis, and then we kind of usually follow up with, say, medication treatment. This requires, sorry, I'm bouncing around pages. This requires a mechanistic understanding of how the body works and the ability to assess the different areas in physiology that are out. This is something that Professor Dirk de Ridder, who has a dual appointment with Otago and also works in Belgium, he's a neurosurgeon, talked about at the recent Neurofield conference that I was at in Santa Barbara a couple of weeks ago, the need to take a mechanistic approach to any brain conditions, not just head injury, but depression and various other things, and to be able to employ a number of different therapeutics at once. And this is not standard really in our present practice. And so there's the issue of having other doctors take on a different way really of appreciating human physiology. It's doable, though. I think the way that it would be doable is that if we were to have clinics around New Zealand that do this and have some really great IT that takes in the qualitative and quantitative results, so questionnaires and tests from people who are symptomatic, runs them through these processes, because we are seeing them work in a good probably 80-90% of people. That just like Mark Gordon's work, we're seeing a majority of people get at least some benefit compared to not being put through this kind of approach, and then be able to demonstrate that statistically that this is actually working. The other thing that I wanted to talk about was the acute setting. This is something where at the beginning of this this slide said that my proposition that we could reduce post-concussion syndrome in New Zealand by 50%. I think there's one very simple maneuver that we could do, and that is to employ a particular supplement. It's sold in health food stores and online, but we use it in medicine, called N-acetylcysteine. So in 2013, and I don't have the paper here in front of you, Dr. Hoffer out of the U.S. Army did a randomized double-blind placebo-controlled trial, so that's a well-designed trial, on about 80 people in the control and 80 people in the interventional arm, and within the first 24 hours gave them some of this N-acetylcysteine orally. That he gave them 4 grams. We use it in the emergency department. We usually use about 12 grams IV intravenously for those who have paracetamol poisoning. In his study, using this approach with 4 grams loading and then about 2 grams twice daily ongoing, he reduced the number of people going on to having ongoing symptoms from, this was blast trauma, so it was a sound wave, not a mechanical blow to the head, but a sound blow to the head, by 44%. So that's nearly 50%. And there's a few other things that we could put in place that I'd be happy to go through with people. I think tomorrow, tomorrow we could actually change things so that if 95% of head injury in New Zealand is mild traumatic brain injury, and all of those people were to receive NAC, I believe, and from what I've seen, we could reduce those that are going on to ongoing symptoms by 44%. My patients who have had concussions, I always get them to know about NAC and use that if they have another concussion, and they'll tell me that within about 2 hours they'll be asymptomatic. I've had patients in the emergency department. It's always a bit debatable because you're busy running something that people don't usually do. Say, for example, a young guy hit his head on a bunk bed and has had previous concussions, so he has delayed concussion. Often people get delayed concussion if they've had previous head injuries, and the inflammation just kind of takes a little while to get going. It's a bit like a hungy. You just put some paper on it, blow on it, get the fire going again, and the brain will do that. So people who have a head injury and it's a little while later, maybe a day or two later, that they're symptomatic, that just about always tells you that they've had some other brain insult, whether it is that they were born by forceps and they had a bit of a brain injury with that, or they had meningitis when they were younger, or they were in a car accident, or whatever it is. And so he came into the emergency department. We had to have the lights off, and he was sitting there with a terrible headache. I gave him NAC. I put some lights on his head, so we talked about biophotomodulation. I had my flex beam there and put that on for about 5 minutes, NAC, and about 2 hours later, he's wandering up and down the hall like a typical teenager in the bright lights of the hospital looking for some food. So we could do this. We can do this. We can do this in the acute setting. We can do this in the long-term setting. What it requires is that we need to change the way that we're approaching it. And I'm really happy to have further discussions about it. Why would this make a difference? I believe that New Zealand is a place that if we put this in here, and because we're a small enough country, we could demonstrate this model for the rest of the Western world. We need to do this to save our country money. So if we had a 44% reduction in the number of people who are going into that whole pathway of the concussion service and ongoing need for care and time off work, very easy. And it probably, NAC for a course, in bulk might be $33 versus $30-something versus, is it $3,000 to $5,000 that is attributed to each patient that goes into the concussion service? These conversations, I believe they need to be had. And what's the holdup? The holdup is the idea that we don't have enough studies. So I can talk about that. I've talked to the local guys in the ED, and they said, well, that the study by Hoffer was done in the U.S. Armed Forces. It wasn't done in the Armed Forces and not in an emergency department. We need an emergency department study. We've found in the clinic NAC to be effective 3 years out in about 70% of people to improve some of the symptoms, and then we'll go after the other areas like their microbiome if that's indicated or whatever. So I'm sorry, that's probably a really kind of waffly kind of round the bush talk. Sorry, and I'll dash back to the emergency department and sorry for the rush, but I hope you guys are well. I'm happy to have further conversations, and congratulations on forming the Billy Guyton Foundation.